Last leg here. You know, everything's relative. We're talking about scale and scope today, this morning. I was just talking with Sharon and telling her about our work in ALS, where it's just went into clinical trials, not by us, but based on our work. 50 people are going to be treated, and these guys are talking about 50 million, so I'm humbled. Anyways, this is my pleasure to invite Dr. Sharon Bruce up here. She's chair and head of Community Health Services. Sharon, thank you.
Thank you. And thank you very much, Dr. Hicks, for inviting me today to introduce Dr. Blanchard. It's a great honor to do so. So I'm the department head at Community Health Sciences right now. So Dr. Blanchard is a professor in Community Health Sciences and also holds a Tier 1 Canada Research Chair in Global Public Health. Dr. Blanchard is a graduate of the University of Manitoba. He received his Doctor of Medicine here, and then he went on to Johns Hopkins, where he received Master of Public Health and a PhD. I first saw Jamie. I remember the first time that I ever saw you. He was an epidemiologist with Manitoba Health. And he was working in, it was probably the chronic disease unit, it may have been called. And he was giving a talk on diabetes epidemiology. And I guess I was a research associate then, I happened to be there. But he worked, his unit produced the very first population-based report of the epidemiology of diabetes in Manitoba. And this was in about the 1990s. And this is a really significant report because it really laid out the magnitude of the epidemic of diabetes among First Nations, diabetes and diabetes complications. And it probably was, the first time that those who weren't inside community got a sense of the severity. People in community, of course, knew what was happening for quite a long time. But Jamie and his team were the first to really make it clear to the rest of us. And his team also developed a really comprehensive diabetes strategy for Manitoba. And I bring this up because it is a memory of mine, and this is the area that I focused my academic career and research in. And so he was really instrumental in more than one field. Dr. Blanchard has always had an interest in global issues, global health, and communicable as well as non-communicable diseases. And so when an opportunity arose, he made a shift and started looking at HIV and developed programs in India. So he's always had a focus and maybe a bit forward thinking in terms of team science, team-based work. They started that very early, and also multidisciplinary work. So he worked with people like Dr. Frank Plummer, Dr. Stephen Moses, Dr. Alan Ronald, and I think the president at the university at that time was Dr. Emeka Zathmary. And they, in 2008, there were many others, and 2008 established the Center for Global Public Health. And this was in the Department of Community Health Sciences. And that was really a real foray into programs. And there had been a lot of work, certainly in infectious disease in a global context, but development of public health programs. Well, they've had great success, and in 2020, the Center for Global Public Health became an institute. And this was in recognition of their work and also the place in which global public health was being held at the university. The Institute for Global Public Health sits within the faculty now, and they have very large research and program platforms in India and Kenya. And they also have key research and technical support programs in Pakistan, Nigeria, and Ukraine. And they, as a group over the past decade, have attracted over $250 million in funding. So they've been very successful. recently, I received a note, and it was, someone sent this to me, and it was a serious question raised by an Indigenous scholar by the name of Dr. Desi, I think from UCLA. And so she asked this question very seriously. She said, is it possible to have community impact like saving lives impact while in academia? And they went on to say, there's got to be more to this than publishing articles that will only be read by a few people. And they said, it's getting harder to reconcile working in the ivory tower, if that's all this is about. So I think that, well, we saw the work that we've seen today, and Dr. Bhuta, and I think what Dr. Blanchard will show us, is that, yes, it is possible to have life-saving impact while working in academia. Dr. Blanchard, through his leadership and all of the researchers who work with them, they work in partnership with local and national governments and communities. And they design research projects, do analysis together, and they move research findings into policies and programs. And they've demonstrated the impact of their programs over years, and it's demonstrated in many ways, but some of the significant ways in response to Dr. Desi's question is in decreases in morbidity and decreases in mortality, as well as significant community mobilization. So yeah, I think we do have an impact sometimes. So it really is a pleasure for me to introduce Dr. Jamie Blanchard, to celebrate his leadership and also the fine work that he does and all of his colleagues at the Institute for Global Public Health. Jamie. Oops, sorry.
Thank you, Sharon, for that wonderful and very humbling introduction. Normally, I would be terrified to be asked to speak after Zulfi because his talks are always so inspiring and wonderful, and today was no exception. But it's also a great honor for me because Zulfi has become one of my real heroes in global health, and I think you can see why. He's really been at the forefront of changing how the world thinks about child health and child survival and newborn health, and now increasingly other parts of young life. And I think one of the really important parts of his contribution has been to show many people like me who kind of were meandering a bit early in our career trying to think about, how we can have an impact. I think he's one of the great examples in Canada and globally of how you can be within an academic role, but then really think big about what you and your colleagues can achieve. And today what I'm going to do is talk a little bit about how we might have to change in the way we think about academia and our role in academia and the role of academic institutions in order to meet the new challenges. Because I think that society's changing and academia has to change as well if we're going to be relevant. First, I'm going to start, I didn't know until about 5 or 7 years ago what the actual mission was of our university. And even though I've been here for about, I don't know how many of you knew that, how many of you ever seen the academic mission? Well, the mission of our university is not that different from a lot of universities, but it's to create, preserve, and communicate knowledge, and thereby, notice this clause, contribute to the cultural, social, and economic well-being of people of Manitoba, Canada, and the world. This is quite a mouthful, but I think what it does is it articulates 3 important facts. One is that this university aspires to not just develop the knowledge, but also to communicate the knowledge, to have the implications shared. Secondly, the purpose of that is to improve well-being. And I think that's something that's sometimes lost by those of us in academia. The third component is that it's not just for Manitoba or Manitobans, but it's for Canadians and it's for the world. And so we need to sometimes go back to these kind of senses of mission within academia and think about what that means and what the implications are. Now, public health is a great space for living out a mission like this, because it's the combination, it's been defined as the combination of skills, sciences, and activities directed to maintenance and improvement of health of all of the people through collective or social action. So you can see here how closely how one might define public health aligns with the mission of a university or an academic institution, because it really brings together the development of knowledge, but also the translation of that knowledge into impact. You know, I'm often asked that question: why should a university have a global public health program? They've proliferated over the last decade or two. Almost every university now has a global health program. But I don't think we often think about why, other than the fact that there's new opportunities for students through global health. So I think that one of the reasons that these are some reasons why universities should have a global public health program. First of all, I think it fulfills a university's commitment to service through the improvement of the public's health. Having a global public health program gives real scope for service. It promotes the development and dissemination of new knowledge through research, so it provides more opportunities for translating research. I think it provides wider opportunities for learning for both faculty and students. If you can think beyond the borders of the catchment area of your university. And I think importantly, and increasingly importantly, it fosters collaborations with institutions of different types and from different contexts. I think this is really important. But I think that there are clouds on the horizon, and these clouds have been gathering for quite some time, because increasingly society is asking how the scientific enterprise, how academia really contributes to the well-being of society. So though we have these aspirations, I'm not sure that society can always articulate or even identify ways in which their university is contributing to their well-being. And this has been interrogated by a number of people. There's a group of social scientists in Europe who really identified this even 2 decades ago, talking about the fact that in science, the culture of autonomy, this idea of being in an ivory tower and undisturbed in the development of our science, is being transformed into a culture of accountability. Sometimes too much. Sometimes, political winds shift, and it's kind of like, well, what have you done for me lately as an academician? But that transformation is there increasingly. I think, though, that there's also been a shift towards what's been called socially robust or context-sensitive knowledge. In other words, it's not just about creating abstract theories and other kinds of knowledge, but also thinking about the testing of this knowledge in different contexts. And I think the third dimension that's been identified is this idea of reducing the divide between experts and the public, between users and producers of knowledge. And it's not just out of sort of socially responsible principles. It's understanding that the interaction between experts and the public, or so-called experts and the public, is considered an important precondition for technological innovations to occur. So a lot of innovation comes out of that interaction, per se. Michael Gibbons put a finer note on this over 2 decades ago in a paper, in an opinion piece he wrote for Nature. He said that it's really important to move from what has been favored in science for a long time, which is scientifically reliable knowledge, to more socially robust knowledge. He says it's superior to reliable knowledge both because it has been subjected to more intensive testing and retesting in many more contexts, but also because of its malleability and connective capability. And this, I think, is an important point. It's the product of an intense and continuous interaction between data and other results, between people and environments, applications and implications. And I think some of the work that Zolfi was referring to earlier about how a lot of the learning around what to do next or how to address some of these big challenges in public health really comes out of interactions with people in the community, understanding how people live and how they interact with each other. Now, we've kind of operationalized a way of doing this as an academic institution through a rubric or through a concept that we've called program science. And what we define as program science is this idea of trying to achieve population level impact. The question that this person asked of Sharon, how do we achieve population level impact, aligning with public health program objectives, not necessarily research objectives to begin with? Program science also envisions this integration between policymakers, program planners and implementers, and community groups. And in essence, program science is perhaps more aligned with transdisciplinary research models rather than what's currently in favor, which is called implementation research or implementation science. So I'll try to explain how they might fit. Well, first, I'll describe a little bit about what we mean by program science approach. Well, here at the University of Manitoba and through our institute, it involves three essential engagements. One is field-level program implementation. If we're not able to develop experience and innovation on the ground, our knowledge becomes without context. It's not socially robust. We need to have that applicability and that experience on the ground. And so all of our programs have some component of field-level program implementation. There's also the research and technical support that we offer, both with our implementation partners, with governments, with policymakers. And then there's the whole process of translating the knowledge that we gather into products that can be shared as global public goods and disseminating them. The practical implications of taking a program science approach is that we then have to embed the research into programs. In other words, we don't do the research and then tell programs this is what our research found. It's more about thinking about the programs and then bringing research into the whole program cycle. It aligns with the program logic, not necessarily the research or knowledge dissemination model. So it moves away from that concept of knowledge translation, which is I develop a knowledge product, now I translate that to people who need to know about it and hope they do something about it. It's really more about saying, what is the program trying to achieve? How can science help solve some of the difficult problems that programs encounter? And therefore, program science research agendas, they evolve continuously, emerging from questions that arise from the various aspects of a program cycle, the planning and design of a program, the implementation of a program, the scale-up of a program. But this kind of a model poses some really important challenges. For science, one of the challenges is that you have to sequence and interweave research activities across time with different questions. So the agenda, the research agenda, and the hypothesis generation is a rapidly evolving process. It's sometimes very difficult to synchronize your research timing to leverage program investments and implementation. The timeline for setting up a research project is very different from the timeline of implementing a program. And this is a continuous problem. And there's also the real complexity of trying to implement transdisciplinary research, bringing different researchers from different backgrounds together to work on a real-world problem when we actually come from very siloed research structures, whether even siloed within departments, but certainly between departments and between faculties and academic institutions. For programs, there's problems in that a lot of times they don't have a lot of latitude over changing things. So if they do get new evidence to change what they're doing, they don't necessarily have the latitude to change because of policies, because of their funding structures, et cetera. And there's also real constraints that people in programs have in terms of influencing research agendas. It's very difficult for somebody in a program to pose the question a priori and influence researchers to respond to that. So I think if we think about program science versus transdisciplinary research has been defined as a process of collaboration between scientists and non-scientists on a specific real-world problem, really getting at the crux of what we're trying to do in program science. However, the implementation of results is not necessarily for transdisciplinary projects. So a lot of the models that have emerged for transdisciplinary research are still from the perspective of the researcher, not from the perspective of results or the program. And so what we see is that this is just a rubric that shows the difference between multidisciplinary, interdisciplinary, and transdisciplinary research. And I think the important thing here is that the transdisciplinary research tends to be much more focused on outcomes and much more focused on the synthesis of new disciplines and theory. So if we think about program science partnerships, how do we do this? And I think in order to do this effectively, we need to come together with some common conceptual frameworks. To bring researchers and programs and policymakers together, we need to have the same concepts. Programs are increasingly focusing on things like optimizing effective coverage. Dr. Butta referred to that in his talk, looking at different components of effective coverage across the continuum of care. Programs also incorporate explicit models to deliver multiple public health interventions to achieve impact. And there's an increasing emphasis on approving service delivery models and platforms and interfaces with communities. In science, there's a growing emphasis on embedding research and iterative research and moving beyond testing the efficacy of single interventions to examining the whole implementation process and the challenges. So there's been a number of different papers written about transdisciplinary research. And I don't want to go into a lot of detail, but what I want to show is, and contrast, is the difference between looking at something as through the lens of transdisciplinary research versus through the lens of a program. So if you look at this generic model for impact generation, you can see that really it's obviously been written by a researcher, because they're talking about the co-production of knowledge, the development of new knowledge and new competencies, flowing into better decision making, and then sustainable transformations. This looks very generic to a program person. A program person's thinking about what is the impact I'm trying to have and what are the pathways towards that impact. They're not thinking about knowledge in a very generic way. They're not thinking about pathways to getting knowledge into practice. They're thinking about, how do I do my program better? How do I have impact? How do I increase equity? So this is a different kind of a model. This is a model that's written or put together more by people who are thinking through a health systems lens. So here you can see that the ultimate impact here in this model is survival of the mother and the newborn, prevention of stillbirths. The proximate factors leading to that input are things like coverage of programs, equity of the coverage of programs. And then what the factors that lead into those proximate factors are both household and individual context, and then the program and service levers, the content of their programs and services, the availability, the readiness, the quality of those services. And then, of course, there's distal factors that influence that. Those are the policy and system levers, the macro level context, political and economic, the community level context. So this is a very different way of thinking about a research agenda, because you can see here, this is an agenda that's thought through from the perspective of how will we have impact. And the questions that researchers will be asked is, how do these link together? What impact am I having? What's happening with coverage and equity of programs? How is that related to the program and service leaders and the household and individual context? Those are the types of questions that can help a program. But again, the paradigm is different. So I'm going to talk a little bit about, give an example of some work that we've been doing in Uttar Pradesh in India. This is something that our university's been leading for a number of years. It started back in about 2014. This is a project that's an embedded technical partnership with the government of UP, Uttar Pradesh. And the purpose of this is to improve family planning, maternal and newborn health and nutrition, effective coverage, outcomes, and equity. This is the real objective and goals of this whole enterprise. So we have an embedded technical partnership. What we have is we develop technical strategies and learning. We have a collaborative network of technical partners like Johns Hopkins University, Chicago, Community Empowerment Lab, Center for Social and Behavioral Change, a number of different technical partners. We develop a learning and strategy refinement processes. We have a gender and equity analysis and integration component of that. This all feeds into our technical partnership with the government. We also have a transition and sustained impact strategy, which is really about how to build systems to continue to sustain the impact going out. So this is an example of how an academic institution can provide ongoing and direct, a direct role with the public health program. And I'll try to sort of unpack some of this. So for those of you who don't know, Uttar Pradesh is the largest state in India. It has a population of about 240 million people, spread across over 100,000 villages. 78% of the population is rural. It has about almost 6 million pregnancies and 5.5 million live births each year, which is 1/5 of all of India's. Over 11,000 maternal deaths a year. Over 180,000 newborn deaths a year, and over 230,000 infant deaths a year. So about 5 to 10% of all global infant and newborn deaths happen in this one state in India each year. If it was a country by itself, not counting India, it would be the 5th largest country in the world. And any of you probably couldn't put it on a map. But this initiative was really taking on the challenge of working with the government and all of its resources, its $5 billion a year annual health budget, and thinking about how it could be redesigned to address maternal and newborn survival. So what we did is we looked at the priority interventions for family planning, maternal and newborn health and nutrition. We looked at it at the health system level, at the facility level, at the community level. We measure, we analyze, and we innovate. We look at it through the lens of effective coverage. What's the population need for these interventions? What is the contact coverage? What proportion of the population are accessing services? And if they're not accessing services, why are they not accessing services? If they access the services, are the services ready to receive them? And if not, why not? Are they receiving services of sufficient standard? If not, why not? How can that be improved? And are they actually achieving health gains? So really this whole rubric articulates what the research questions are across the intervention pathway. As we discover this, we adapt and scale up solutions. We bring it back into the program to improve the availability, quality, and utilization of services across the continuum of care. We also translate and disseminate findings more broadly in India and globally. So these were the focus areas. Just to give you an example in the first 2 phases, we're now just starting into the 3rd phase of the program. At the community level, we really focused on improving the availability of antenatal services in the 1st phase. We improved, for the facility, we wanted to really look at sub-district facilities, making sure that there were enough delivery points, making sure that the basic newborn care and maternal care was improved. And at the health systems level, we looked at the basic availability gaps in human resource, drugs, equipment, etc. In the next phase, we really started to look at the quality of services, the quality of antenatal care, the quality of mentoring, shifting towards more facility strengthening, the first referral units. Now that the basic delivery care was there, looking at how we could improve the facility strengthening. And at the systems level, moving to the more complex issues. How do we improve the human resource for health, particularly looking at strengthening the availability of specialists, obstetricians and anesthetists and pediatricians, and creating better systems for using data. Now, when we started, we had ingoing hypotheses, as you normally would. We wanted to improve the use of antenatal and delivery care in Uttar Pradesh, so the increased access and use of antenatal care. We had a very naive theory of change. We thought that if we just increased the knowledge and skills of the ASHAs, the frontline workers, through training and mentoring, they would then counsel women about antenatal care and delivery through their home visits and birth preparedness. This would increase antenatal care and institution delivery, and thereby reduce maternal and newborn mortality. It wasn't a bad theory, but it was wrong. And we learned that because we were tracking what was happening with our work. These are the ways in which we were wrong. Most women were already interested and motivated to receive antenatal care and to deliver in safe facilities. We had this idea somehow, I don't know how, but we had this idea that the problem was that women weren't motivated for it. The problem was, and it became very clear within the first 8 months, I would say, the main problems were lack of accessibility of antenatal services and delivery facilities. Women couldn't get out of their village to go to the sub-center for their antenatal visits. They had transportation gaps. They couldn't find a vehicle to take them somewhere. And they had lots of family roles and constraints within the village that made visiting services outside the village very difficult. The community health workers didn't need more training in how to be a counselor. They needed more support in more effective planning for their outreach. They were overloaded with counseling duties and educational roles that limited their effectiveness in roles for linking to services. And they had real difficulty in reaching more marginalized community members who were both sociocultural and geographic gaps. So within a village, quite often the most disadvantaged were in a far-off hamlet. But the woman who was the frontline worker who was working in the main village didn't really have time to go out and spend and get out to the hamlet. And so this was a main problem. So we worked with the government. The government has purview over all of these programs. And so we worked with them on changing the paradigm. So we worked with them to completely reconfigure their antenatal services to be village-based. So basically, moving from a model where women come to the facility for antenatal care, we said, well, you already have village health and nutrition days once a month in a village, mostly for just routine immunizations. Why not tag an auxiliary nurse midwife onto that village health and nutrition day, and so that every month you have a nurse midwife going into the village for antenatal care. Give her the equipment, find a place within the village for her to do this. And this was really focusing on availability and accessibility, and allowed the ASHAs to fulfill a linkage and support role rather than trying to sort of figure out how this woman was going to get to the sub-center. The second thing that we did is we increased the accessibility of facilities for delivery. We found there was big geographic pockets where there just wasn't a delivery point. They didn't have staff, or they didn't have the equipment, or they didn't have locked doors. They just didn't have the facilities. So we just mapped all of that out. And we really had overestimated the issue of knowledge and motivation. If women had a place to go for delivery, they wanted to go there to deliver. They weren't wanting to deliver at home. They were delivering at home because the options were not there or not accessible for them. And you can see that what ended up happening is a complete transformation within really 2 or 3 years in terms of antenatal care. So if we look at the proportion of women with early antenatal care in the 5-year period between the 4th National Family Health Survey and the 5th National Family Health Survey 5 years later, you can see most of the red zones, which is 0 to 40%, have early ANC. None of those were in the lowest, and most of the blocks, most of the districts had really moved into a much better situation in terms of early antenatal care. Similarly, if we look at institutional deliveries, 2 things to note. If we look at between the 2011 to 15, which is just before the project, just before that, and then in 2015, and then 2019 to 20, you can see that there's been a huge increase in the institutional delivery rate, and that there's been a huge closing of the gap between rural and urban. So that this geographic equity gap. The equity gap by income has also closed considerably. There's still a gap, so that the poorest are at 60% and the richest are at 80-some%. But there's been a real closing of the gap there as well. If we look at full immunization coverage for children, you can see that 2 things. First of all, there's been a substantial increase over the 5-year time period. But there's also been a situation where the high priority districts, which had the lowest immunization rates, are really catching up to the the rest of the districts. So there's been a tightening of the geographic gap. And there's been key improvements in labor and delivery practices in public facilities, which is where most of the delivery. So if we look at labor practices, including advanced management of the 3rd stage of labor, these are just 2 different types of surveys. One is the program data, and one is the external evaluation data. But you can see that we went from about 50% AMTSL to 90+% AMTSL within a short period of time. some basic essential newborn care areas, support for early initiation of breastfeeding, skin-to-skin care, cord care, just weighing the newborn, substantial increases over a short period of time. We also found substantial increases in the prevalence of the use of modern contraceptives over a period of time, and again, a closing of the gap between the lower districts and the higher districts. And I suppose not surprisingly, we've seen a bit of a bending of the curve in mortality as well. So that the NFHS4, which reflected data up to 2015, in the 10 years prior to that, there'd been pretty stagnant change in UP in terms of neonatal mortality. But in the last 5 years, there's been a substantial increase in the reduction at about 5% per year. And this is reflected again in infant mortality trends as well. So I think that's just an example of how embedding researchers and people who can look at health systems from a number of different angles can really influence and change programs and have a real impact on lives. So why aren't universities doing this? Why are we not involved in transdisciplinary research? Why is this not happening in every institution? Well, I think that it's because there's a lot of constraints within academia for doing this kind of work. And I've just focused on the constraints here. So if we look at the focus, the ability to focus on major problems like neonatal mortality, so some areas are seen as unrealistic. Oh, we couldn't do that. That's too complicated. Lack of integrative research frameworks. Within universities, we're not very good at integrating disciplines and faculties and departments. There's not that many models about how to do this within academia. If we think about trying to put together teams and team research, often within universities we see skills as competitive. There's a tension between solo and collaborative work. There's the power prestige differences between social and medical sciences. There's this worry about diffusion of focus and loss of identity. I hear this a lot from early career investigators particularly. They say, well, I need to find my niche. I need to find out what I'm doing special. And this happens for the first 5 to 10 years. Whoops. I'm going forwards and I'm going to try to find my way back. And then, of course, this then bleeds into the sharing of credit, which affects promotion, tenure, publications, funding. Who gets the credit for this work? And so universities have every disincentive for team science. In terms of training, there's historical barriers across fields, locations of departments, funding is limited for training. When we think of institutional policies, Dr. Butt and I won't share exactly what it was, but we were talking about the fact that universities enact rigid policies that make the kind of creative, dynamic work that's needed in global health almost impossible to do. Centers lack funding. If we think about funding, grant applications are much more challenging to put together if it's team science. It's much easier to say, this is my research objective, these are my 3 hypotheses, these are my hypothesis-specific methodologies, and this is how I'm going to do knowledge translation at the end of it. That's how a typical grant is written. So grant applications for team science are much more complicated and very difficult to adjudicate for peer review committees, the way they're structured. And we recently had a meeting in New York with some executive editors from The Lancet, and we talked about the fact that journals need to do a better job of finding ways of publishing this kind of work. Because without publication, how do you communicate it? And how do you get credit for that as well? And again, peer review is hard to do in these areas. So we need to think also about the different ways in which publications can be done. So I'm going to complete with some thoughts about changing paradigms. I think that if we're thinking about changing paradigms within academia, we need to change the research environments, the academic environment. We need to shift roles and incentives of research institutions to become more accountable. If a university becomes accountable for what's happening in health within their area, it will change the way they do things. It'll change the way they teach. It'll change the way do service, it'll change the way they do research. There needs to be flexibility in research and team roles. There needs to be credit given for participating in a team, not just as an individual. Programs need to change as well. They need to expand their theories of change. They need to change their logic models. They need to go from rigid cause and effect things, these so-called log frames. They need to move from that to more generalized models, more open and adaptive kinds of program models. And policy and funding needs to change. We need to elaborate funding models that support better partnerships between programs and research consortia. I have to say it's a continued frustration for me that in Canada, we have almost completely siloed off our program funding in global health through Global Affairs Canada from CIHR and from IDRC. We have these sort of, I don't fund research, I don't fund programs, and so how will you build this kind of responsive community for program science and team science? I think we have some great examples from our institution, and I have to say that the leadership, starting with Dr. Safmary back in 2008, has been really remarkable in terms of giving us the latitude to change the way we think about models in health. So one of the main things that the university's done is it's completely changed the funding model, particularly with respect to indirect costs of research. Now, the indirect costs of research, instead of the majority of it going back to central administration, the majority of that comes back to the programs and is reinvested in our programs in the field. And all of the individual principal investigators have foregone all of their own indirect costs of research and also put it back into that pot, so that we're able to sustain teams and program partnerships for longer periods of time without the vicissitudes of up and down funding from granting organizations. Within our institute, we've not just developed a research and education portfolio, but we also have director level portfolios for program delivery and technical partnerships. And we've formalized more partnerships with organizations that are both academic, but also with government structures in low and middle income countries. These are often multi-partite partnerships with defined programmatic roles. And we're moving towards trying to bring together the so-called upstream and downstream research. This is a concept that we're working on with a couple of our funding partners. The idea of building program science hubs with major public health programs like the one in Uttar Pradesh, but then linking them to interdisciplinary research clusters, where the program science partnership will focus on the within program embedded learning, looking at the appraisal of epidemics or this health situation, measuring and monitoring gaps, bringing new ideas through iterative learning and hypothesis generation. Whereas the research clusters will focus on data science, social sciences, health sciences, biomedical sciences. The so-called upstream solutions need to be fed with questions from programs. And then they need to have a very quick cycle of getting those innovations into practice. So instead of using a pipeline metaphor, where you're constantly filling the pipeline with new innovations, the idea is to actually say what's needed here, and then challenging the research community to come up with innovations. And I think that's a model that we need to move towards. I'm going to stop there. I'm sure I've gone a bit over time, but I wanted to thank you all for your attention. And if you want to know more about our institute, we finally have a decent website, so there it is. Thanks. Happy to take questions if there are any.
McGill University. So I was wondering so most of us are students, so how can we try to move this kind of approach forward, either within our local departments or maybe for some of us in our career later, but like, is there things we can do in a more pragmatic way?
So I think the first thing is to find people within your institution who are doing this kind of work and see whether you can get experience working with them. There's great people at McGill. Tim Evans is there. He's sort of been at the forefront of a lot of public health development in global health. So I think that's the first thing, is to try to find people, even if it's not necessarily within your discipline, but if it's aligned with something that your research is focusing on, see if there's a way that you can plug in, and maybe learn about other disciplines. Say, you know, this isn't necessarily my field, but I'm really interested in this general topic. I want to learn more about how other disciplines look at it. So I would say try to get a little bit of range in your experience at this stage of your career, and find people who are doing that kind of creative work. It may not even be at your institution. There may be other people that you want to engage with. I think the second thing is that as a student, try to read outside of your discipline. And I know it's very, very difficult, but there, you know, even if there are things that seem tangential, like if you're in basic science, read something about population. If you're in population science, read something about the basic sciences. So try to read and educate yourself about different ways of thinking about things. I think that would be. And the third thing is, Dr. Butta presented some amazing materials that many students don't sort of get that big picture, the macro picture. I certainly know I didn't get that macro picture when I was in training. So I think also look to those kinds of things. Look to that kind of literature. What's happening in the global debates around health? How does what I'm doing fit into that, even if it seems tangential to begin with? I was inspired. I went to Rice University in Houston maybe 2 years ago. And they've got this great project on improving new technologies for saving newborns in Africa in low resource settings. And with a bunch of biomedical engineers. And what they're doing there is they're basically saying, okay, what's the problem? What do we need here? We need a new bilirubinometer. We need a new CPAP machine. We need something else that would work in these environments. They bring together all the biomedical engineers from different countries, and they say, let's problem solve that. So the program need is there. It's been defined by people who are experts in maternal, newborn, and child health. The biomedical engineers now have a project to work on. So they're not thinking about, oh, this would be a neat thing. They're actually meeting a demand there, and it's a very, very dynamic. Why are we not doing that in other sciences? I don't know. So.
Thank you.
Hi, thank you for your talk. So I'm Hiba from the University of Montreal. I would have a classic question for you. So the work you presented regarding global public health are usually done in low-income countries, so whether in Africa or South Asia, which is really interesting because obviously it's related to problem-solving issues. Do you see? Oh, okay. Whatever. I think you hear me.
Yeah, I can hear you. Thank you.
Do you have any explanation why is it maybe easier to go to those countries? I can understand that our institutions here could be more complicated to deal with, but what's the explanation you give to that reality that we see?
Okay, you've caught me in a bit of an unguarded moment. So I would say, so I think there's 2 or 3 things. First, I would say that compared to a lot of, this might sound a bit surprising to people in Canada, but compared to Canada, or I'll put it the other way, compared to a lot of other countries, Canada is incredibly conservative in terms of trying new things in public health. There's just not a lot of space or interest in doing something differently. And I say that having worked for 10 years with a provincial government, but there's just not a lot of space for really creative ideas. It's partly the disciplinary boundaries that are around things, the idea of task shifting or really meaningful community engagement just isn't as robust, I would say, in Canada. I think that's the first thing. Second thing is more positive. There's a lot of good programs working in Canada and a lot of good academic programs, and so we can't all be working on that. So I think that it's important to do things in Canada, but there's also important to work to do elsewhere. And I would say that our role elsewhere is, we currently have 0 Canadians in India, but we have 1,200 staff. So it's all people that have sort of built up in our program, that are working locally. We're learning more from them than they are learning from us at this point in time, and that's a real privilege for us. But it's not as though it's a bunch of Canadians helicoptering into India. The team there is very much an Indian team, and our role is really to help facilitate a lot of those relationships and partnership and do mentoring, I think. So I think those are the main things. I think these models are needed more in Canada. I think that universities are going to have to start saying, we have really, really tremendous problems here. Where's our accountability to solve them? And it's not enough to say, well, we have 10 researchers working on that problem. At some point, a university has to say, we're going to take on, for the next 5 years, substance use. And we're going to hold ourselves accountable for improving that at a population level. Until universities start doing that, I don't think things are really going to change.
Thanks for answering this question. I know it can be tricky. Thank you a lot.
Hi, my name is Zahra. I'm from Queen's University. My question is sort of similar to what you just mentioned about helicopter research. I work in partnerships with community organizations, and I'm wondering, what sort of challenges do you have working, establishing partnerships with organizations in low to middle income countries, and how do you approach that? If you're trying to go there, build this partnership, and do the research, so that's the first part of the question. And the second part is, how do you handle the helicopter research idea where this population could possibly be over-researched and you just don't want to go there, do the research, go out, or just go there for 1 year and then, and that's it,
So those are really great questions, and I think they're one of the real. It's at the core of what a lot of universities should be asking themselves about global health research. I would say that at least in our institute, we don't have what I call free radical projects. So we will not, at least I won't support initiatives that are just a one-off. I've got a grant to do this. I'm going to do it for 2 years, and then I'm going to publish a few papers. So we only do research in the context of long-standing partnerships. So our partnerships in India go back 20 years, some of them. And they've gone through maybe 7 different funders, sometimes no funders, and where we have to sort of bridge the gap. So if we can't make long-term commitments to communities or to institutions, then we're not going to be able to avoid so-called helicopter research. So I think we just have to change the way we think about these partnerships. We have to be, so we've worked in a lot of different countries, but we focus on 4 countries. And it takes a lot to get us to move to a 5th. We're thinking about a 5th country, so we've been doing more work in Ukraine, but that's only because we've had 7 years of partnership with an institution in Ukraine. So we're thinking about maybe making that one of our focus countries. But we don't have a bunch of different research projects with a bunch of different principal investigators in different countries, because that inevitably leads to helicopter type of research. I know that Dr. Bhutta has worked with some communities for decades in southern Pakistan and Sindh, learning, supporting, et cetera, long-standing engagements there. I think really successful global health programs and research are built on long-standing engagements with partners, with communities, with countries, because otherwise you just have a very superficial relation and a very superficial learning, actually, about things.